So thank you so much for having me, and I will be speaking about sleep as self-care. And as during my presentation, I'll talk about what caregivers and care partners can do and how diets, so the person living with cognitive impairment and the care partner can help each other to get better sleep. All right. So I have no conflicts of interest to disclose. All right. So the objectives I have in general are to define sleep, to discuss the prevalence of sleep disturbances in general and in African Americans, to describe some changes observed with sleep due to age and cognitive impairment, discuss some ways to measure sleep so as to identify sleep problems, and then finally review some non-medication methods for managing sleep problems. So as I was preparing this presentation, I was kind of searching through the literature, and I found two manuscripts that were pertinent to today's presentation. So the first one was that Robbins and colleagues, they found that persons taking 30 minutes or longer to fall asleep or sleeping fewer than 5 hours per night had a higher risk for incident dementia. And they reported that the risk for all-cause mortality was higher in participants who reported difficulty maintaining alertness some days and most every day, napping some days or almost every day, and who had very poor or poor sleep quality and sleeping 5 or few hours per night. Another group of researchers, Sabia and colleagues, they found that the lowest dementia incidence was observed among those who slept 7 hours per night, irrespective of age. At which sleep duration was measured, and that short sleep duration was associated with higher risk of incident dementia at all ages. So while we do not yet understand in totality the relationship between sleep and cognitive performance or impairment, we know that poor sleep is associated with a higher risk for cognitive impairment, but also that when we have cognitive impairment or we see and interact with people who have cognitive impairment, they tend to talk about having some change in their sleep pattern. All right, so what is sleep? Sleep is a period of inactivity and restoration of mental and physical function, and it includes alternations between non-rapid eye movement and rapid eye movement sleep. So when we are asleep, our brains, they do, and we talk about this later, polysomnography, where they see our brains go between stages 1, 2, and 3, and that's non-rapid eye movement sleep. Then rapid eye movement sleep, and it alternates throughout the night. Non-rapid eye movement sleep has 3 stages, and it's about most of the nights, about 80% total of nightly sleep, and rapid eye movement is about the other 20%. And what are some functions of sleep? So it helps to integrate new memories and existing knowledge, and also to restore the brain chemistry to a normal balance. So in terms of thinking about restoration of brain chemistry, we see here the glymphatic system. So this is a system that works in the brain, and what it does is that it clears waste from the brain. So it's a fluid, there are fluid-filled spaces around the small arteries. So those are called arterioles, capillaries, and venules. Those are small veins in the brain. And it promotes the removal of soluble proteins and metabolites from the central nervous system. So when we're awake during the day, and our brain is at work, then it makes waste products and it makes metabolites like beta amyloid and tau. So whenever we are asleep, then the glymphatic system is at work, and it helps to, and it promotes the removal of these proteins that are built up during the brain. But it also functions to take things to the brain that it might need. So the glucose, the lipids, the amino acid, and the neurotransmitters that the brain uses, it takes those to the brain. So the glymphatic systems function mainly during sleep, and the increase in clearance happens during non-REM sleep. During that third stage of sleep, the slow wave or the deep sleep, is where we see an increase in the glymphatic clearance. So it is recommended that adults between 18 to 64 or 65 and above get at least 7 hours of sleep per night. But we see that more than 1/3 of adults do not get adequate sleep of at least 7 hours per night. And there are changes in sleep that accompany aging. So we might see that adults over 65 might tend to wake up earlier. So they have earlier wake times. They typically wake up about an hour earlier than younger adults, but they usually go to bed about an hour earlier than younger adults also. And this is due to, we call it the circadian rhythm. So that is our 24-hour cycle. And because of the change in the circadian rhythm cycle that happens with older adults, there's an hour advance in that circadian rhythm. And because of that, there is a change in the way that when melatonin is secreted. So that contributes to them going to bed earlier and then waking up earlier. And they also report reduced sleep consolidation. So that means when you go to bed, that you tend to stay asleep for a longer period of time and not wake up frequently or more often. But with older adults, they might wake up a few times, and that might be to use the restroom due to chronic conditions, or even naturally wake up just because of aging. And they tend to wake up multiple times during the night, sometimes have difficulty falling and staying asleep, and have less stage 3 sleep. With cognitive impairment, also sleep does change. And this is because we see that there are neuronal pathways. So our brain, we have neurons, and these neuronal pathways that start or maintain sleep can be damaged due to the dementia process. There could be also changes in the circadian pacemaker of the body. So that is where some neurons are located in the suprachiasmatic nucleus in our hypothalamus. So that's a part in the brain where it's located. So kind of like, you have your heart pacemaker that maintains the rhythm of your heartbeat. This circadian pacemaker also maintains the rhythm of our body on this 24-hour cycle. So when there are changes in that pacemaker, then we see changes in the person who has cognitive impairment in their sleep pattern. And then third, there may be changes in the brainstem regions and pathways that regulate the sleep cycle. And what is the evidence that we see? So we see day and night sleep pattern reversal. So a person living with cognitive impairment or dementia might want to sleep during the day and they're awake at night, or they might wake up frequently during the night, or they might have increases in daytime sleepiness and napping. So sometimes as the disease progresses, one of the things that persons or care partners or caregivers might report might be that the person is sleeping a lot more than usual, or they've seen a change in their sleep pattern. So it could suggest that the disease is progressing. And a group of researchers and I conducted a secondary data analysis, and we wanted to see the impact of Alzheimer's disease patients' sleep on their caregivers. But what I wanted to point out here was that about 60% of caregivers actually reported that the person living with dementia had at least one of the following sleep disturbance. So they were taking at least 30 minutes or more to fall asleep. They were having 2 or more awakenings during the night, wandering at least 1 time weekly during the night, loud snoring more than 2 times weekly, and daytime sleepiness. So for me, what that suggested was that, at least almost 2/3 of persons living with cognitive impairment do have some type of a sleep disturbance, but also caregivers are aware that this is happening. And if they're aware that this is happening, it could suggest that they also would have disturbed sleep as a result of, multiple factors associated with the person living with dementia's sleep pattern. So there are about 16 million caregivers or care partners of persons living with dementia, and about 14% of them identify as Black. And sleep disturbance is prevalent among caregivers in general, with between 66 and 92% of them reporting poor sleep quality. A group of researchers, Gao and colleagues, they did a meta-analysis. So that means they looked at all the research that are out there with caregivers or care partners that looked at sleep duration and sleep quality. And they examined them and they found that caregivers received approximately 2.5 fewer hours of sleep each week per night, and they receive significantly less total sleep time than non-caregivers. So they found that caregivers sleep on average about 6.7 hours nightly, which is less than the recommended 7 hours of sleep that we recommend and we would want to see. And also subjectively, when they asked caregivers about their sleep quality, they said that it was poorer compared to aged match controls. They spend less time in the restorative stages of sleep, take longer to fall asleep, and spend a significant amount of time awake after sleep onset. They also have inconsistent sleep-wake times and multiple nightly awakenings. In an intervention that my mentor has, it's a psychoeducational intervention for caregivers, we added an examination of sleep at baseline. So we looked at insomnia and we also examined sleep quality. And when we looked at them at over time, when we examined the intervention, caregivers in general who received the intervention actually had an improvement in their sleep. So they had a reduction in insomnia symptoms, and then they had a reduction in their sleep quality, meaning that their insomnia symptoms and their sleep quality improved. But I just looked at baseline wanting to see what the Black and white caregiver numbers were. And I was quite surprised, and maybe I shouldn't have been, that when I compared with the insomnia numbers. So that looks at amount of time taken to fall. Do you have a hard time falling asleep? Do you wake up multiple times during the night? Do you wake up early? How does it affect you during the day? Those questions, there was significantly different in terms of the mean between white caregivers and Black or African American caregivers. White caregivers in terms of insomnia, and their report was 6 on their mean compared to African Americans who had 10. And the same thing was seen with their sleep quality. So sleep quality, the number, anything above 5, suggests poor sleep quality. So both white and African American caregivers had poor sleep quality, but you can also see there's a significant difference here in the number or in the mean score for the white and the African American caregivers. Okay. Does somebody have a question? All right. Okay. So in the general population, we see that African Americans are reported to have more frequent disturbances in sleep. So that means difficulty falling asleep, early morning awakenings, higher risk for short or long sleep, lower sleep continuity, and greater daytime sleepiness, lower sleep quality, and low percentage of slow wave sleep, and greater percentage of sleep apnea compared to non-whites. What I told you about previously that was in caregivers, there's not a lot of literature specifically looking at sleep in caregivers. So this was, I looked generally across African American population and what they report with sleep. And there can be multiple factors that contribute to this poor sleep, such as racial and ethnic discrimination, working in occupation with unstable work schedule or not having a standard work schedule, living in less safe neighborhoods, environment with greater noise and light, and acculturation stress. So whenever you observe poor sleep or a change in your sleep pattern in the person living with cognitive impairment, or even as a caregiver or care partner in yourself, what do you do? Well, we always encourage you to see your healthcare provider or have your annual visit. And at your annual visit, speak to your healthcare provider about the change in sleep. So whenever you tell them, oh, I've seen this change in sleep, or I'm having difficulty with sleeping, then they'll evaluate you. They'll do both subjective and objective assessments. So subjectively, they will ask about, they'll do a sleep history. So how do you feel about your sleep problem? What is your quality of sleep? Tell me about your sleep schedule. Specifically, do you have problems with falling asleep or staying asleep? Do you feel sleepy during the day? What are some of the things that you think affect your sleep pattern? And then they'll ask you about your sleep hygiene practices. So that means, when do you exercise, your exercise routine, your caffeine intake, what your sleep environment looks like, and then they'll evaluate general emotional and physical problems. So depressive symptoms, and depression is associated with sleep patterns. So they'll ask you about depression, anxiety. They might ask you about physical problems such as pain or any other chronic condition that you have, urinary symptoms, things like that. They may also have you complete sleep diaries for a few days so they can see exactly what your sleep pattern looks like. And they might ask you to also complete questionnaires such as the Insomnia Severity Index, the Pittsburgh Sleep Quality Index, the Stop Bang, to maybe evaluate for sleep apnea, or the Epworth Sleepiness Scale. Those are just some questions they might ask you to complete. In terms of objective, based on what they see and hear from that, they might then refer you to do a polysomnogram. And now they have at-home ones or they have in-lab ones. But the main things that they do for those are they're going to look at your electrical brain activity along with your muscle movement, your eye movement, your heart rate and your cardiac rhythm, your oxygen saturation and your breathing movements. And all those together are able to tell them stages of sleep. Do you stop breathing while you're sleeping? How does your leg move? So do you have periodic leg movements, restless legs, sleep apnea? They're able to use those to diagnose certain sleep disorders. They can also ask you to wear an actigraph, and that's where a device that's worn on the wrist or the ankle to measure muscle movement, muscle motion, and in conjunction with a sleep diary can help to identify sleep duration and sleep efficiency. So after you've done all that, then your healthcare provider would make, recommendations. So it might be that they, based on what they find, they might manage your medications. But regardless of that, some non-medication things that you can do, the first one would be exercise. And you, the caregiver, and the person living with cognitive impairment, you can do it independently or you can do it together, where the general recommendation is about 150 minutes per week of moderate intensity activity or 75 minutes per week of vigorous activity. And it what's moderate for one person and vigorous for one person might be different. So it all has to do with, before you start anything, getting, evaluating, and speaking to your healthcare provider. And, there are so many things that are, so many videos and training, and if you have Medicare, then they offer silver sneakers. So there are many things and resources that you can potentially use to start doing this. And it doesn't have to be that you do 150 minutes if you haven't been exercising, but you start gradually. So you start once more, you start low and go slow, and build up. A research study done with caregivers found that listening to soothing music before bed, along with brisk walking for 30 minutes, actually resulted in improved sleep quality in middle and older age adults. And also 12 months of moderate intensity exercise. After female caregivers participated in this, they found that it improved their sleep quality compared to a nutrition exercise. Another intervention is light. So research has shown that, and this was done with caregivers, where they compared bright or dim light. And this specific one didn't necessarily result in an improvement in sleep, but 4 weeks of blue-white light result in increased circadian entrainment. So that's where your circadian rhythm was once more, or the caregivers, so this was with caregivers, circadian rhythm was once more back aligned with the 24-hour sleep-wake cycle. And it increased sleep efficiency and sleep time for caregivers. And the similar thing was seen for a 6-week blue-white light intervention with caregivers. Then sleep hygiene. So sleep hygiene are behaviors, are personal and environmental activities that can influence sleep. So these behaviors include maintaining a sleep schedule, including on weekends, um, practicing a relaxing bedtime ritual, whatever that looks like for you. A lot of times that might include leaving the device with light outside of the bedroom, sleeping on a comfortable mattress and pillow, turning off electronics before going to bed, exercising regularly but not within 2 hours of bedtime, limiting caffeine intake after lunchtime and alcohol prior to bed. So we also say if you have alcohol with dinner, try to make that within, not within 2 to 3 hours of bedtime, and not eating a heavy meal also within 2 hours of bedtime. And to the extent that is possible, keeping the bedroom quiet, dark, and at a cool, comfortable temperature. We know that a lot of people have pets, and pets are really great when it comes to, like promoting exercise and getting out and socialization. But a lot of times pets based on where they sleep can be disruptive to sleep. So we encourage persons with pets to keep them out of the bed. Even if they're in the bedroom, they have their own bed in the bedroom, their individual independent bed in the bedroom. Then cognitive behavioral therapy. So that is a multi-component intervention. And that is actually the gold standard recommended for if somebody has insomnia. And it involves cognitive and behavioral techniques. So some of these are stimulus control, sleep restriction or sleep consolidation, relaxation training, cognitive restructuring, and sleep hygiene education. And the goal of CBTI is to replace unhelpful sleep habits and thoughts and to reduce arousal associated with sleep. So stimulus control therapy actually aims to strengthen the association between the bed and the bedroom and sleep and to produce a consistent sleep-wake cycle. So whenever you're doing that, we say to you, minimize napping during the day. Some people don't nap and some people do nap and they feel like they have to nap. So we say, if you want to nap, do your best to nap a short nap, less than 30 minutes before 3 p.m. Go to bed only when you feel sleepy. Get out of bed if you're unable to sleep. And this can be, if you're a person living with cognitive impairment or if you're a care partner for somebody who lives with dementia, you, the care partner, can get out of bed and go somewhere else. But the person with cognitive impairment may not remember to do that. And if they're unable to, get out of bed, if they're in bed tossing and turning, if they wake you up, then it might be that you both need to get out of bed because you may not both be able to fall back asleep and go somewhere else and do something until you see signs that they're sleepy or until you feel sleepy again. Um, and use the bedroom only for three things: sleep, sex, and sickness, and wake up at the same time each day. With sleep restriction, the time that is spent in bed is reduced to the actual sleep duration based on sleep diaries. So we ask you to complete these sleep diaries and we look and we see how long that you're actually asleep and we reduce it to that time. And that creates some mild sleep deprivation. But for older adults and for people living with cognitive impairment, we have found that sleep compression is an alternative technique to sleep restriction. So that means that the time in bed is gradually reduced until optimal sleep duration is reached. Then relaxation training, that's done to reduce tension and intrusive thoughts that might interfere with the ability to sleep. So you can do deep breathing exercises, progressive muscle relaxation, guided imagery, biofeedback, meditation, any one of those relaxing things that help and work for you. Then cognitive restructuring aims to reduce worry and change misconceptions associated with sleep and insomnia. And that means you're asking yourself these questions. So, if I don't sleep well tonight, what's the worst thing that can happen tomorrow? And one of the things I always say to many of my care partners or the person living with cognitive impairment, the worst thing might be I have to take a nap. Hopefully you don't have to drive extended lengths or you're not operating heavy machinery or anything like that. If you have to do that, then I would say then Maybe you need to take a nap before you decide to do any one of those things. Or if somebody comes to you and say, I'm not sleeping well, what would you say to them? So questioning yourself, or have I had a bad night's sleep before, and what has been the outcome? Was I able to do the task that I had told myself to do? Um, and then finally, sleep hygiene education that I mentioned previously provides some guidelines in general about factors that may help or interfere with sleep. And CBTI can vary between 4 to 16 sessions, but it has demonstrated effectiveness for many different populations for improving sleep disturbance using face-to-face video conferencing methods in individual or group sessions or via teletherapy. And it's also been successful for caregivers of persons living with dementia. So, Black or African American caregivers can work with the person living with dementia or cognitive impairment to improve both their sleep, and they can practice these techniques either independently or together. And they're also trained professionals who do deliver CBTI, cognitive behavioral therapy for insomnia. They are not a lot, and many healthcare providers, many primary care providers may not necessarily know about trained CBTI specialists, but they are there. So you can ask when you go, your healthcare provider, whether they know about any to refer you to or to recommend, or you can look online or see whether or not there are any available in your area. And then mindfulness-based stress reduction techniques, those aim to change reactions to stress by teaching purposeful awareness and acceptance of the present state. So it once more includes techniques such as breathing, body scan, walking, meditations, and yoga. And 2 studies with caregivers showed that it improved their sleep quality after an 8-week meditation training and their subjective sleep quality following 8 weeks of mindfulness training. So I spoke about Gao and colleagues and what they found in terms of sleep quality and sleep duration, but they also looked at interventions for caregivers, and they found 13 caregivers, and some of those are referred to previously with outcomes. And they found that caregivers who received an intervention had better post-intervention sleep than caregivers in the control conditions, and behavioral interventions, so such as CBTI, that talked about sleep hygiene, stimulus control, or light, were associated with better post-intervention sleep quality. So what now? Here are a few suggestions for you about what to do next. If you see any changes, or if you're experiencing any changes, speak to your family, or speak to a healthcare provider who you have, if you're caring for someone and you notice changes in their sleep habits. When you're speaking to them, if it's changes you've observed for someone, or if it's for yourself, be prepared to discuss what you observe or what you're experiencing, when they started, if you did anything to alleviate or make your sleep patterns change or better, and if it helped or if it didn't help. Do your best to establish a nightly routine for yourself and for the person. Reduce lighting at night and increase lighting during the day. So expose yourself or the person to light during the day and reduce it at night. One of the main things I say, and that's one of the mainstays of stimulus controls, if you have a television in the bedroom, take it out and put it somewhere else. Do not look at TV when you're in bed in the bedroom. And I have a current intervention for a study that was funded by the Alzheimer's Association, which I just ended. And that was one of the hardest things, I think, it was a dyadic intervention. So both the caregiver and the person living with cognitive impairment participated together. And that was one of the hardest things, I think, for people who had televisions in their bedrooms to give up. But it's amazing how they talked about how their sleep changed for the better when they were able to just try it for a week. So I say, just try it for a week, see how it works and see what the outcome is, and then we can evaluate and move forward. And then stay active with safe exercises and fun games and activities so that you remain awake during the day, and then you can go to bed and fall asleep quicker, hopefully, when you followed your nightly routine to get into bed at night. And no research or results that I present, you can't do it alone, and you can't do it without funding. So I've been lucky enough that I have been funded by quite a few organizations. So the National Hartford Center of Gerontological Nursing Excellence, that was actually my first funding as a doctoral student, along with a supplement from the National Institute on Aging. I've also received a supplement from the National Institute of Nursing Research, and an ongoing Alzheimer's Association grant that I just finished recruiting for. I also have a K-23 that's funded by the National Institute on Aging, and that also includes developing and eventually testing an intervention for persons living with cognitive impairment and their care partners. So I'll be sharing that poster pretty soon, so look out for it, because we'll be recruiting dyads if you both have poor sleep and you're working together to improve your sleep outcomes. And thank you so much. I think that's it for me.